Hello, everyone. Good day. I'm 𝗟𝗓𝗂𝗋𝗃. I'm the project director for the Health Systems for Tuberculosis project, HS for TB. Welcome to this presentation on government-led contracting. Before we get into the details of it, I'd like to hand it over to 𝗟𝗠𝗜𝐷𝐵NR from the Office of Health Systems to introduce the series. 𝗟𝗠𝗜, over to you, please.
Thank you so much, 𝗟𝗑𝗂𝗋. Good morning, good afternoon, good evening, everyone. I'm 𝗟𝗠𝗜𝐷𝐵NR. I'm the Knowledge Management Advisor for the USAID's Office of Health Systems, where I lead our Learning and Knowledge Management portfolio. As part of that portfolio, we host, USAID hosts the HSS Learning Series, which is a monthly forum to convene HSS practitioners to share, learn, and use HSS evidence to support sustainable health system strengthening. The knowledge and evidence that's shared as part of this monthly series contributes to USAID's HSS learning agenda. And we're really grateful to the USAID HS for TB team for ending a year of really invigorating learning with this debate on government-led contracting. Next slide. And before I hand it back to 𝗟𝗓𝗂𝗋, I just wanted to flag for everyone that participation in the USAID HSS Learning Series is open to the wider HSS community. So if you have a webinar idea that you believe would advance learning on HSS in a substantial way or would be of significant interest to the global HSS community, I invite you to send us an email at this email address you see on the screen. We review webinar ideas on a rolling basis throughout the year and schedule them approximately once a month, and have really benefited from all of the interesting ideas that have come from the HSS community, including this debate today. So now I'll pass it back to 𝗟𝗓𝗂𝗋.
Thanks, 𝗟𝗠𝗜. Let me just take you through the agenda. So we'll introduce the topic of the debate. We'll have the debate. There'll be some Q&A. You're going to see a couple of Mentimeters along the way to measure your reactions and how you think things are going. Next slide, please. And I'd just like to say in 60 seconds what we do in HS for TB. The project is coming into its 5th year now. We work in different areas of finance and governance for tuberculosis. We've been working in Bangladesh, India, Ethiopia, Kenya. The work we've done so far has touched PFM, domestic resource mobilization, contracting out. We are thinking a little bit, well, thinking more than a little bit. One of the focus areas is helping countries eventually transition away from donor funding. And so to that end, we've created a sustainability index that lets countries know where they are on their TB financing, resourcing, budget execution, and programming. And we're also doing a collaboration with the Joint Learning Network that brings contracting experts together from 12 different countries to learn from each other about how to do contracting better. Today's topic is about contracting. It's a topic that elicits sometimes strong reactions from both sides. And we thought it would be good to do this as a debate so that you can hear kind of both sides of the argument and make up your own mind about the role of contracting in health systems. So with that said, I'd like to introduce and turn it over to our distinguished and august moderator, William Wells, from the Office of Infectious Disease TB Division. William, over to you.
Great. Thank you so much, 𝗟𝗓𝗂𝗋, and welcome everyone to this debate. We're very excited to have you here. Before we get into the debate proper, we just want to define some terms, specifically what is government-led health contracting and why might it be important, and then that will be the topic of the debate. So health contracting is, as we're using it here, is hiring not-for-profit, NGO and CSO, and/or for-profit organizations for specific TB or other health-related services. And what we're talking about here is when you use contracting with the country's own procurement system and domestic funds. We'll hear a lot more in the debate about why this might be important, but briefly, contracting of organizations is an essential element in mixed public plus private health systems. It's used in basically all high-income countries, and it allows you to leverage the public sector. It allows the public sector to leverage the skill sets and reach of diverse health system actors. And it offers a pathway for sustainability. Next slide, thanks. So on this second introductory slide, we just, again, want to define exactly what we do and don't mean by contracting. On the far left-hand side is the most generalized engagement approach with the private sector. In TB, we call this public-private mix, or PPM. It really means reaching out to individual private providers, but usually there's no payment involved. So it's just engaging them and maybe helping them with public health tasks, but no payment going from government to providers. Then you get to the more familiar insurance approach, where you're impaneling many providers, probably thousands, but it's a broad standardized service package that's applicable to all providers. So that's insurance. That's sometimes also called contracting, but that's not what we're covering today. Then you have something like, for example, if you want dialysis services to be delivered, you might contract with a narrower standardized package just for dialysis and only with dialysis centers. So that's a handful, but you're still talking about a standardized package for many organizations. Then what we are talking about today is paying individual organizations to deliver a customized package of services. This would be designed under something like a request for proposals, or RFP, and it would be awarded to just one single organization to carry out that individualized package of services. So it could be active case finding for TB, it could be sample transport, it could be IT services, many different things. Next slide, thanks. So we'll now have a quick check-in before we get into the debate. We will launch a Mentimeter, so please click on that and tell us the estimated level of interest of contracting, either in your own country or in the country where you do your work the most. So we've got some threes coming in, some lower and higher. So it looks like a fair range, but centering around 3.5. Great. Well, it looks like there's pretty much every response is covered, but we're centering around a 3.5. So there's definitely some interest there, but also some hesitation, which is perfect for the debate. Thank you so much. Next slide, please. Great. So I'll now introduce the panel all at once, and then they will step through in a pro-contracting and anti-contracting alternating order. So firstly, we on the team that is supporting contracting, Mohammed Ashadul Islam is the Chief Technical Advisor for the 𝗟𝗃 program in Bangladesh, amongst multiple other roles. He's the former Senior Secretary at the Ministry of Planning of Bangladesh, at the government of Bangladesh, and also worked as the Secretary of the Health Services Division, where he led the implementation of the Health Sector Development Program. He's also served as the Director General of the Health Economics Unit at the Ministry of Health and Family Welfare at the government of Bangladesh. We also are lucky to have Dr. 𝗏𝗏𝗏, who is the Infectious Disease Cluster Lead of the Southern Luzon or Calabarzon Center for Health Development in the Philippines, and has extensive experience in the contracting conversation. Rounding out this team is Dr. Sabah Wasim, who is Technical Director of the Health Systems for TB project, with extensive experience across many domains of health financing. Then on the anti-contracting team, we have Farid Abdullah, who's the director of the Office of AIDS and TB Research at the South African Medical Research Council. He's also been formerly the senior manager in the Western Cape Health Department, where he led the implementation of antiretroviral treatment introduction, and was also previously the Africa director of the Global Fund to Fight AIDS, TB, and Malaria in Geneva, and the CEO of the South African National AIDS Council. Finally, we have Dr. Nazmul Huda, who is the country project director of Health Systems for TB in Bangladesh, and was formerly a special advisor to the Gavi Alliance Board and a director of Grameen Bank organizations. And sorry, I believe I missed Neelam, my apologies. Neelam Makajani is the Health Systems for TB country director based in India, and has also been the head of child care projects in India and Sri Lanka. Next slide, please. So as we get into the debate, one request is to listen carefully as we go along, because you'll be asked to vote for the best arguments at the end. To also use the reactions button as we go along to express yourself during the debate. So we're interested in which arguments you find stronger versus weaker, particularly the stronger ones. And also keep your questions and comments going through the Q&A button. So they'll be ready for the Q&A period, but also so we can see along the way which questions are coming up for you. A disclaimer here, the arguments of the debaters do not represent their personal views or the views of their agencies. We've actually set some people up to argue against their personal views. This is a debate. And a reminder, as 𝗏𝗃 said, we put this as a debate topic because there is no one answer to this question. We are focusing here not on a kind of political ideology question. We're focusing here very much on the practical sides. There are definitely practical reasons to do contracting and practical barriers to doing contracting. So we think there are strong arguments on both sides, and we look forward to hearing the voices of the debaters on this topic. Okay, so I think we will now get underway. So I'm happy to hand it over to the first speaker, Dr. Asad, please.
Yeah, thank you so much. Thank you for arranging the debate and the discussion on such a critical policy issue. And thanks, Dr. William, for setting the scene. I hope that our debate and discussion will clarify, and the countries who actually are planning to introduce contracting mechanism will get more clarity from our discussion. I strongly believe that introducing the government-led contracting is not only a viable option for the countries, but rather it's an imperative for the countries as they have been trying to improve their coverage and improve the quality and reduce the cost of their services. Given the, I think, challenges of government-led services, it is a good solution to the existing situation. Before going to the argument for contracting in low and middle income countries, let me remind some of the elements of our proposition. We have been discussing the government-led contracting. We are actually looking into the viability of this strategy for low and middle income countries. And this is a tool being practiced in developed world. And lastly, only for select services. That means we are not proposing that everything will be contracted out, only those services where the private and non-government sector has an economy of scale. So let me put it into the historical background. The perspective is that we know government is responsible for providing health services to its citizens, especially in the welfare countries. And government has been trying to provide it through its own delivery channels. But you will agree that two things appear very prominently, that government can neither cover the whole population or the whole need of healthcare for a given population. Second issue is that in many cases, or in most cases, government provision is not efficient in terms of cost and quality. That actually triggered the development of private and non-government sectors so fast in these countries or in these areas. So countries around the world are looking for tools, techniques, and strategies, how actually they could expand their coverage, improve the quality, and reduce the cost. And contracting of select services with the NGOs and non-government sector is one of such strategies. Now, coming to the point whether it's viable for, I think, low and middle income countries, we can consider the policy and political viability. We can consider the viability of implementation and also sustainability. You probably know that countries like Bangladesh has been planning to introduce the contracting mechanism to supplement its effort for service delivery. And this has been, I think, explicitly documented, reflected in the policy and planning documents. Second issue, contracting is practiced in low and middle income countries, especially with the donor-funded programs like GFATM, Asian Development Bank, and others. And the experience is quite encouraging. And we know the Global Fund's participation and the contracting with NGOs has brought down the TB, malaria, and AIDS control to a satisfactory level. So I hope that for achieving universal health coverage, it's an imperative for the countries. Thank you so much.
Thank you so much, Asad, and I hope everyone's enjoying the Academy Awards music play out. So we will now move to our first anti-contracting debater, 𝗟𝗲 Mukhijani from Health Systems for TB India. Please, 𝗟𝗲.
Thank you, and good morning, good evening to everyone. I would like to actually say, all the points that my opponent just made, they're still not very, very strong, and I'm going to tell you why. And the question that I want to throw back at the audience really is, are the LMICs ready for contracting and assure improved health systems because of contracting? I think that's important. So with changing health needs, growing public expectations, and the ambitious new health goals, they are raising the bar for health systems to produce better health outcomes and greater social impact. We need high quality, efficient, and effective health systems that optimize healthcare. And they have to be consistent, they have to be valued, and will create trust within the citizens and the populations they are supposed to serve. I agree, and I agree fully with my opponent that it is difficult for any government to provide all the healthcare needs on its own. Therefore, contracting is important. But the question here is, are the low middle income countries ready for it? And do they have a strategy that is going to be visionary and sustainable? However, I think, and some of the points my opponent just made about cost cutting and all of that, contracting should not be seen as a replacement of an inefficient government system. It is not, contracting cannot be used as a bridge for an immediate gap. And if not sustained, it dies a natural death. Now, let me just point out a couple of points. The challenges and limitations to make contracting work in many of the low middle income countries are many. First, healthcare improvement is a slow process. And in most countries, healthcare is seen as a cost center and not as an investment, because of which many low-income countries do not invest in this for long term, and therefore it becomes a stopgap approach. The partnerships are asymmetrical, balance of power and parity are rarely seen, and all of the relationships are transactional. Secondly, most governments, as I said earlier, lack the vision and capacity to manage the prerequisites of an effective healthcare system. The institutional mechanisms like governance systems, financing, monitoring, close management of it, grievance redressal systems are missing. Corruption and fraud is common in many low-income, middle-income countries, leading to substandard contracts, lack of transparency. Contractors have always focused more on winning bids and less on doing the best job. Not all low-middle-income countries have a fully developed and a mature private sector, and this can lead to lack of competition, influence the performance of the players, and therefore adversely affect the services. Government on its own can provide the economies of scale. The costing, if you come to costing, it's always going to be the government who has the economies of scale, and they have the access to the last mile citizens. It is the accountability of the government to provide quality healthcare. And dependency on contracting can lead, definitely by the government, if not done by the government, lose touch with the common citizen and the needs of the common citizens, and therefore lose sustainability of it. My final points: criteria for decision-making for contracting is cost, capacity, competency to manage, and continuity. LMICs have a long way to go for that. Before you vote, I urge you to answer the questions. Do you believe that LMIC countries can do contracting and therefore provide quality healthcare systems? I don't think so. Thank you.
Thank you, Neelam. I would be scared to be up against you in court. Very nice.
Thank you.
Okay. We will now turn to the second argument. Eva-Marie will give us our second pro-contracting set of arguments based on her experience in the Philippines. Please, Eva-Marie.
Thank you very much. I just would like to point out that Dr. Neelam might have given us a few points, but there are some arguments which I would like to point on. Primarily, I would just like to say that health is a concern of everyone, and not only of the public nor the private sector alone. The government contracting out specific health services to be provided by the private sector sends a strong message that an integrated and coordinated government contracting with the NGO or the private sector benefits the community most. In an archipelago like our government, we have difficulty in covering the entire population, specifically in hard-to-reach, geographically isolated and disadvantaged areas. Contracting organizations or established private healthcare providers with extensive manpower and investing capital to deliver services in such areas extend the coverage of government services. They reach underserved areas, especially in remote or resource-scarce regions. Contracting is a measure to bridge service gaps, and contracts are often needed to put sufficient focus and prioritization on public health actions, as contracts can be designed to deliver specifically on the implementation of such actions. In countries with social health insurance like our country, even public providers will tend to focus too much on clinical care, which is directly reimbursed by insurance payment. This makes it even more important to issue and manage contracts that specifically target public health action. Our government is evolving as it ushers the universal health care. It is not yet that good at reaching out to large number of small private clinical providers. However, there are NGOs that have developed very efficient models for reaching these private providers to assist them in contributing quality TB services via the so-called public-private mix. Contracting such PPM NGOs has led to doubling or almost tripling TB case notification from individual private clinical providers in some municipalities. Lastly, contracting can allow for the continuity of provision of donor-funded public health services by transitioning the donor-led contracting role over to government as donors withdraw. This retains the expertise and contribution of existing donor-funded TB NGOs and other private sector actors and allow for the expansion of a health system capacity. So I beg to disagree. The Philippines is for contracting, even though we're low and middle income country.
Thank you so much, Dr. Eva-Marie. You got the music right on time. Thank you so much. So we now turn to Farid Abdullah. Please, Farid, to give us the second anti-contracting narrative. Thank you.
Thank you, William. I'll pick up from where Neelam left off by starting to say that when all is done, government is ultimately held responsible for delivering services such as those for the treatment and prevention of tuberculosis. Government cannot walk away from this responsibility. Contracting out services to NGOs or for-profit organizations comes with the risk that they can walk away from this responsibility. An NGO might decide they do not want to do this work anymore. Often NGOs are built around charismatic individuals, and when those individuals change their minds or move on or retire, pass on even, then there is a risk that the NGO stops doing this work and can walk away with it. In the case of private sector organizations, they might find after the first round of contracting that the margins are not attractive enough for them, and decide to go and do some other business which could be more attractive. And in the end, government once again gets, to use a Filipino term, gets left holding the bag. We all complain that governments are not efficient, they lack capacity to implement core programs, and instead of helping to build the capacity of the national TV programs or local delivery, frontline delivery institutions, we are proposing to contract out these services and these functions. And this might have the risk of undermining the health system strengthening efforts that we all are clamoring for. Funders need to understand that government can absorb overhead costs in ways that NGOs and the private sector cannot, and often have absorptive capacity, unused capacity at the front line, whereas NGOs or the private sector must add additional costs of overhead, of paying salaries to their managers, and they must fully fund all their costs. And this might even be at risk of being more expensive. And I would go as far as saying that in that case, it would be a form of allocative inefficiency. Donors often want their funded programs to be contracted out, citing multiple government weaknesses, failures, and inefficiencies. But as soon as the donor funding dries up, then they turn to government to take over these services, and the original concerns seem to vanish into thin air. Now, if I can pick on my wonderful friend Eva-Marie again, to take the Philippines as an example, where we know this is one of the countries with the third tuberculosis, and they have decentralized their services to 16,000 municipalities. And instead of focusing on organizing and putting their municipalities together, simplifying their operations, contracting out would lead to greater complexity and perhaps even poorer results for tuberculosis. Thank you.
Thank you so much, Farid. Okay, some very good arguments there. So now we turn to the final pro-contracting debater, 𝗬𝗲 Waseem. Please, 𝗬𝗲.
Thank you, William, and I would commend my colleagues for their very heroic efforts arguing against the motion, but I'd like to remind them that the role of NGOs and private organizations is well established and in providing health services and not really up for debate. NGOs are doing the heavy lifting in almost all of the TB programs that we are working in. And this is on the basis of the requests that the national TB programs that they themselves makes to donors. So unlike what my previous colleagues said, it's not so much donor driven, but as based on country requests. So if you look at the Global Fund's last grant cycle, about 30 to 40% of the funding from Global Fund was requested for local organizations. So the only difference that that is currently there is that the funding is provided by donors, And the question that is up for debate is whether governments are ready to contract and manage these contracts, not whether NGOs are ready to provide those services, NGOs and private organizations. So the main arguments against contracting organizations that I've heard today are twofold. One is that it's the government's mandate to provide services. And by contracting, they would be somehow admitting defeat and conceding ground to NGOs. And the other is against, the weak capacity or corruption argument that, Neelam put forward. On the first, about government's mandate, certainly the government has a mandate, but the government's role is stewardship, which is not equal to direct service provision. Government can use contracting as a purchasing tool and to ensure an optimal mix of private and public service provision. And in fact, it's the government's role to leverage the vibrancy of the private sector. As you know, in our countries like India, Bangladesh, and all the Asian countries, the private sector is much more vibrant and has much greater capacity to deliver. And so it's the government's role as a steward to ensure access to services, not to directly provide them. On the capacity and corruption issues, unfortunately, that's not unique to contracting, and it's something that we all encounter in all health systems issues. In fact, I would argue that capacity can be built, and India is a great example. For the last 10 years, they have been working. The Central TB Division has been working to set up systems and has for contracting and has shown great progress in getting results. So that's something that can be built. And on the corruption issue, in fact, I think concerns about corruptions are overwrought. In fact, in our work, we find that corruption might have a dampening effect on bureaucrats taking risk in contracting. And there's much greater accountability of private sector providers than there can ever be of public sector providers. So I think on all of these counts, contracting is a tool that governments can certainly use to maximize returns and maximize efficiency and equity. Thank you.
Thank you so much, Sabah. Very nice arguments. And now we have the final debater, Nazmul Huda from Bangladesh, will give us the final anti-contracting arguments. Thanks. Nazmul, we don't have you on screen. Did we lose Nazmul? Nazmul, you're still on mute. Nazmul, you're on mute.
Mr. Moderator, I don't think government-led contracting is a viable option for delivering select health services in low and lower middle-income countries. In many countries, health is a constitutional obligation of the government, and contracting health services may be perceived as denial of the government to provide health services to the citizens. There will be risks for losing popularity of the government due to contracting. The second reason I have against government-led contracting, that is, government may have multiple layers, and it may be difficult to secure buy-in of all of them. That might be a challenge for implementation of contracting. So private organizations run after profit, so it may be expensive to also to buy health services at reasonable price from them. So government in many countries invested a lot in public sector for health service delivery. So in case of contracting, that infrastructure may remain underutilized. In course of time, the government may become dependent on few organizations, eventually leading to monopoly. Government in many countries employ most of the doctors and nurses. The private sector may not be able to hire skilled manpower in that case. My pro-contracting colleagues, they have mentioned that about the concern that NGOs, they have a legacy in low and middle income countries, but government also many governments, they have also legacy in providing services to the people and hard to reach areas also. And in many countries, the private sector, they are very vibrant and powerful. So it also needs a special capacity to handle them in many countries, and that many countries also lack that capacity, so that they maybe not be able to control that private sector effectively. And there might be some provider issues, provider satisfaction, doctors, nurses, and they may be poorly addressed in case of private sector. So there might be more, job unsatisfaction, a lack of job satisfaction in private sectors. And my pro-contracting friends, they have mentioned about accountability. So I believe that government cannot avoid accountability for whatever they do in any sector. So as such, the government also have to ensure accountability in health services too. So thank you very much.
Thank you so much, Nazmul. It's always hard to go last, but I think you came up with some nice new arguments. All right, so before we're actually going to have you vote eventually on this pro versus anti, but before we do that, we're going to keep the participants in their current roles of pro versus anti. So again, they're still giving their assigned roles rather than their actual personal opinions, and just ask some questions of them. I encourage you to put questions in the Q&A box. I'm going to get things started with a couple of questions myself, but please add your questions to the Q&A box. So the first question is kind of a double-barreled one to Fareed. Fareed, could you respond to a couple of the arguments from the pro-contractors saying, okay, well, you need contracting to access key and hard-to-reach populations, and you also need contracting for surge support if there are new initiatives and you don't have government personnel to take on those new initiatives. Do you have a response specifically to those two arguments? Thanks.
I think that it's fair to think about bringing in NGO partners, especially with hard-to-reach populations, but these generally tend to be funded by donors. Sabah made reference to the Global Fund, putting a lot of money into exactly that. And I can tell you that every country that's in the transition out of the Global Fund is now being asked by the very Global Fund to take over these contracts. And there has been almost no success in this area whatsoever. So in the long term, there might be a need for governments to develop this kind of capacity. Governments all over the world run community health programs, outreach programs, and there are good reasons for governments to do that. And then, William, remind me your second question.
I was more around the sometimes the civil service rules mean that it's difficult to hire additional staff, or sometimes impossible. So if you have a new initiative and you need more personnel, how can you do that if you don't have the tool of contracting?
Yes, I think the argument for contracting is not that it's cheaper or less efficient financially. So this is not a debate about money, but about a better way to deliver these services. And if the government doesn't have the money to do the program itself, it won't have money to contract out other agencies to do that. So I don't think that's really an argument that comes into this debate. It's about where countries are in their development and their level of organization and what they're able to do. And I think the difficulty here comes back to that simple thing, which is, do you have the ability to manage these complex contracts and to make sure that you're getting the value for money that you're contracting for?
Great. Thank you so much, Fareed. Much appreciated. So I now have a couple of questions for the pro contractors. 𝗟𝗲, first going to you. You did touch on this a little bit in your comments already, but maybe you can expand on it a bit more. Corruption was raised by the anti-contractors. That corruption could be during the award of contracts or during the invoicing and payment process. What are some of your sort of additional responses to that issue? How do you see that as not being an argument that would force people to not take up contracting?
Sure, yes. And thank you, William. And as I mentioned earlier in my brief remarks, corruption is endemic and corruption is an issue that has different aspects, different facets. So when you think about public sector provision of services, corruption manifests itself as not providing services, right? So, a healthcare worker does not show up in the facility and does not provide the services at all. That is something that is addressed by private sector provision. So there's much greater accountability. So when you contract out to an NGO, they are much more responsive because their payments are tied to production of outputs and outcomes. So that's one aspect of corruption that is addressed by private contracting out services. There are concerns about corruption in during the process of contracting and in handing out contracts, but I think they are overwrought. In our experience, there's much greater scrutiny at that step. In fact, there are systems very much in place for procurement that make sure that the process is very transparent and open at the contracting stage. So concerns about corruption in making contracts are kind of overwrought in our experience. Where there are concerns, corruption or the perception of corruption that does have a dampening effect on contracting is when bureaucrats are overly sensitive about corruption allegations and they are risk averse. So when they have to make payments and verifying results and making payments, that's when the fear of being blamed as being corrupt stalls that process, and they're not that enthusiastic about entering into contracts, making new contracts. So those are new, it's not really corruption, but a risk aversion to corruption that can impact. And there are ways to deal with it. So you can have a more transparent contracting process. You can have open forums where there's dialogue between a private and public sector to mitigate those corruption concerns.
Great. Thank you, 𝗟𝗲. And anyone who was at the Health Systems Research Conference, corruption was a major theme there, and it could be a webinar in itself. So my last question before I turn to the Q&A section, the Q&A box, is to 𝗟𝗏. 𝗟𝗏, another concern from the anti-contracting side was about delays during the contracting process and during the payment process. And both of those can threaten the continuity of service provision if the contract is delayed or the payment is delayed. What is your response to those concerns?
Yeah, probably it has been preempted, some of it by Dr. 𝗟𝗏, that corruption and other things has different dimensions. However, there are ways, these all challenges are tractable and can be actually minimized, addressed by regulatory and management interventions. For example, we could actually minimize the delay in contracting by setting up the tender validity period. So tender should be awarded within this period, and it should be done very prudently. No delay, no lengthy, not very quick, this sort of thing. So tender validity period and submission, asking for the real sort of essential papers, documents, and I think scrutinizing on only the submitted documents only, no negotiation. This could actually help, I think, expediting the contract awarding process. So these all are actually management issues, and we could actually put it in the regulatory sort of requirements so that contract will not be delayed. The second issue is the payment. So it also be, I think, incorporated within the conditions of the award of the contract, that when, how much, which part of the payment will be made at what conditions are made. So it should be, it is more of capacity and more sort of teamwork of this team spirit. So if the team are capable of, I think, monitoring the activity and ensure the accountability of the contractor, it's possible to get payment, I think, within time. And there are, I think, provision for incentive, disincentive, punishment, this sort of thing. So these are the actually management issues and could be actually organized. Thank you.
Great. Thank you so much, Ārshad. Very helpful argument. So I'll now turn to the Q&A box. Thank you so much for the questions. There's some interesting questions coming in. I want to take one from Mohan Kohli, who asks about there have been arguments for anti-contracting, that it will not lead to development of capacities in-house in the government, but there is the possibility of transfer in knowledge. So can we look at a middle path of buy until you are able to build? So in other words, purchase the service while you kind of learn how to deliver that service yourself. So it's not a complete one way or the other. Would anyone like to take that one? I think maybe Neelam, you can address that one.
Sure. So, well, that's been the case in India, if I take that. So we have been doing a lot of contracting in India. And I'd like to ask my colleague, has it improved the quality of services so far? So we have been buying, but not building enough. So is that, unless the points that I was making, is it viable for now? Have the governments made enough investment that even if we go with the option of build to buy and stop buying and make it for yourself, has that succeeded so far? So what have we learned so far? Even if we did do that as a temporary strategy, that we will buy till we build. But what is the vision behind all of this? So again, it's the same thing. At the moment, the low middle income countries do not have a viable strategy that even if they take that path of buying while they build and do not put in investments for continuity and sustainability, it will always become a dependency thing. It's going to continue with the dependency and continue depending on foreign donors. So there has to be a very solid base and a strategy before we even jump into that approach.
Great, thanks, Neelam. Any response, Ava Marie? Can I put you on the spot for the pro-contracting side? Any response to what Neelam just discussed and this general question of, is it possible to buy first and then build capacity along the way?
Well, currently what we have to do is really have a very good we should ask, especially our policymakers, to have strengthened or very good policies with regards to contracting. Policies emanating from the central offices down to the local government. So once there is a solid policy, then the strategies would usually follow it. Aside from that, currently we are taking the opportunity to learn what we can about contracting, not only the ones at the local government unit, but likewise our leaders. We're taking this opportunity to learn everything that we could in contracting. Aside from that, when we've already learned all the technical aspects, what we could do is to transfer all this knowledge to the ones who are next in line to us. So these are the things which we could certainly do at the moment. And aside from that, we have to make sure that our policymakers or lawmakers, we have to make sure that they reduce regulations so that we can increase contracting that's very viable for our country. It is very important for us likewise to have a clear and compelling rationale for the value of contracting so that we could influence the rest of the stakeholders and more of our government leaders for buy-in for the contracting. So I think not only learning, but likewise transferring the knowledge that we have learned from JLN or USAID, that's how we would go about this in the future.
Great.
As what we said, not everything should be contracted out. There are certain aspects which should be ahead, or certain services which should be contracted ahead of the rest. And nothing is perfect. So we have to start somewhere. So we have to start in our own little steps.
Great. Thank you so much, Eva Marie. The last question, there's some great questions here, but I just want to have one last question for Fareed, if I can, Fareed. So there's a question from Asmita Singh, pointing out that if you're doing contracting, then there are benchmarks to monitor performance by the private sector because they're being paid for that. So there is actually a focus on cost for services. When it's public sector delivery, there's rarely a focus on cost for service delivery. They're just allowed to deliver in the sort of usual way, and nobody's kind of looking at cost. What can be done to address that, or what would be your reason for saying that's not an argument for contracting?
Well, these are two different operating systems, right? So measuring the cost per service delivered sounds like a smarter thing to do, but what really matters are the outcomes. And just measuring the cost per service comes with its own perverse incentives, which include doing all the easy cases, doing the numbers and referring up the more complicated cases. So I don't think that's an argument. And what should really happen is outcomes should be monitored. This whole shift globally to value-based care, where both the outcomes and the costs are factored into a measure of efficiency. Thanks.
Great. Thank you, Fareed. I appreciate the argument. Okay, so it is now time to vote. Tom, are we ready for that? Great. So it's another Mentimeter, same process, and you're voting on which side of the debate you think won the day. So please either vote for the pro-contracting side or the anti-contracting side. All right, pro-contracting gets the first votes. And he is catching up. Interesting. Great. Well, I thought it might be a little bit closer, but it looks like despite their best efforts, of the anti-contracting side, the pro-contracting side has carried the day. I will note that all of our anti-contracting debaters were somewhat under duress. Definitely we had fun putting Neelam as the first anti-contracting voter because she's very, very, very pro-contracting. So kudos, and Fareed also. So kudos to the anti-team for putting up valiant arguments. I think as we've gone through this process, both in preparation for this debate and in fact in the live session today, the real conclusion is that everybody won and nobody won. From the pro side, contracting is an essential tool for ensuring access in specific technical and geographic areas, and the contract mechanism can drive improvements in quality and efficiency. From the con side, I mean, you really need to choose carefully when deciding what to contract. So as multiple people have said, this is not about contracting everything. And you need to work very deliberately on capacity strengthening for contracting, and addressing these risk areas around transparency, monitoring, payment efficiency, all of which were identified by the con side. I think, you know, capacity was mentioned by both sides. One side said government doesn't have capacity to deliver services itself. The other side said government doesn't have capacity to contract out. So capacity is an issue either way. But some of these sort of key words that came out about things being too transactional, there not being continuity, too expensive, weakening of the public sector, these are all valid concerns that need to be addressed. But then again, on the pro side, extending coverage, sustainability, the vibrancy of the role of NGOs and private sector, and government being in a stewardship role rather than having to deliver everything itself. Again, these are all very valid arguments. So with that, I would just thank all of the presenters very, very much again, and pass back to Ksenia for to close us out. Thanks, Ksenia.
Yep. Thanks very much, William. So a few thank yous. Thanks to to Anjali and the Office of Health Systems for series and letting us speak. William, thank you for the synthesis at the end and the masterful management of the process. Thanks to our speakers, but most of all, thanks to everyone who joined us today for taking the time out of your busy days. If you'd like to learn more about our work, or if you've got any advice for us, you can either email myself or William. Our emails are up there. Or if you can get your phone out in time, you can snap the QR codes, and that'll take you to our kind of 2-pagers on the different aspects of the project's work. So once again, thank you all. It's really been a pleasure and an honor to be with you this morning. And we wish you a good day or a good night, depending on where you are. Bye-bye.